Hello, everyone. This is Michael Misko with Misko Health Law with this week's Kyra Secure Growth Without Risk presentation. And we're going to talk about some risk areas based upon observations from some recent post payment audits by Blue, Cigna, United, and the like. Probably the number one thing that I want to address, because it seems to be a target in almost every audit that I've seen recently, is massage services. Now, fundamentally, um, there's been some cases where you have employer self-funded plans that specifically write massage coverage into their summary plan descriptions, or there is massage coverage under the health insurance carrier's certificate of coverage. Um, Long story short, just because massage is covered doesn't mean that you should necessarily be billing it. When you look at medical necessity issues, especially where you're billing 4 units of massage, and it looks more like, uh, a head, shoulders, knees, and toes, full body relaxation type massage, as opposed to a focal massage of, specific tissues, you're going to run into medical necessity problems. The other issue that comes up with massage is delegation. Where licensed massage therapists are used, that's fine. In some cases, payers do not pay for services of licensed massage therapists. So, to get it paid, the massage services are billed under the performing or under the supervising chiropractor. And that is fine, because there is a difference when a massage therapist is operating within the scope of their license. They are evaluating the patient, um, determining what to massage, where to massage, and how long to massage. When they're working for you as a licensed chiropractic physician, they're in effect a chiropractic assistant. But to substantiate that, and where delegation to a chiropractic assistant is permissible, you need to substantiate that you are performing the examination, the diagnosis, and you're writing a specific order for the massage therapy, so that they are being told what muscles to hit, how long to hit, and what technique to use. That's got to be in your documentation if we're going to salvage the delegation. The worst thing in the world is to allow your massage therapist to write soap notes where they do subjective analysis, objective analysis, and identify muscles are tight and how the patient's doing, and order their own treatment. That tells me that that is not a delegated service, and that would be inappropriately billed under your license, because you're not controlling the care. So, in order to establish billing under your license as opposed to the massage therapist, make sure you have a detailed order that tells them exactly what muscles, is substantiated by your objective findings on your examination, diagnosis of muscle spasm, hypertonicity, whatever it is that you want them to work on, and a specific order for what techniques they're to use and for how long. And normally, those massages will go maximally 15, 20 minutes. Uh, per body region, like head, neck, or neck, mid back, low back. um, Very rarely you're going to get into extremities or finger popping or ear popping or things like that. So just be mindful. If it were up to me, I would tell you, if you're going to do massage, make it cash, take it out of your treatment plan, especially if you're treating those muscular issues with other therapies in your office, like stem, manual therapy, and things of that nature. So be very, very cautious when you're billing massage. And don't forget, at least where CCI, the Correct Coding Initiative, applies, massage is a component of manipulation. And to bill it separately, you need to support the 59 modifier. And if you're doing manipulation in that region, you won't be able to justify that, and they will take that money back. So be very careful with massage. Similar to the concerns with massage, I'm still running into cases where docs are still trying to separately report manual therapy with a 59 modifier on top of their CMT. It is a very, very highly audited code pairing. Payers know that it's probably, especially when you're billing 98941, that it's likely not going to be justified unless it was in an extremity or something like that. Issues that they pick on when they don't bring up the bundling issue is both medical necessity, In some cases, they find that the therapy is duplicative of some other more cost effective therapy like electric stim. Second issue is delegation, similar to massage. Third issue is the 59 modifier, meaning if you're performing it in the same body region, even though that's not how the modifier 59 is defined, most payers are going to want to bundle it. Now, in a recent case, a provider thought he was really smart, and because muscles that they were addressing or that he was addressing through manual therapy were attached in the region of the sacrum, he would purposefully not manipulate the sacrum even though it maybe needed it, in order to justify separately reporting 2 units of manual therapy and therefore making much more money. Very, very, very bad idea. We had to roll over on the manual therapy money because there's just no justification for it, and the idea that we would argue to the payer, well, he found subluxation in the SI or the lumbosacral joint, but didn't manipulate the sacrum just so that he could bill for manual therapy, suggests that you're purposely altering treatment in order to bill more money, which is contrary to the contractual requirement to perform care in the most cost effective and least costly setting. So we couldn't make that argument, and we had to fold on the manual therapy. Normally, in a very hyper technical sense, because the muscles aren't usually attached to the regions of the spine. I'm not saying that his theory was wrong. It's just that's not how payers interpret it. And because there was a 98941 being billed, and the massage or the manual therapy was performed to soft tissue structures, interestingly enough, that were also being massaged in the same region where manipulation was performed. It's just too many hills to climb. So those would be issues that you are going to run into trouble on. Um, Therapeutic exercise, if you're doing resisted stretching techniques to improve range of motion or deal with hypertonicity, break up adhesions, as long as it's active and you're doing resisted motion for the same therapeutic outcome, even though it's not as fun for the patient, but where your documentation details the exercise you're performing, sets, reps, and the time, and it's performed by the doctor in most cases, that's going to be a way that you can get paid for something other than manipulation that doesn't create the same bundling concerns. Okay. Upcoding of manipulation services. Commonly, uh, when they look at manipulation, there are manipulations performed outside the region of significant complaint. So patient comes in complaining, let's say, of neck and upper back pain caused by some injury. And during the course of the exam, the doctor also, consistent with his or her training, starts asking the patient, well, how does your low back feel? How does this feel? How does that feel? And they develop complaints outside the area of complaint that caused the patient to seek treatment. In some cases, there aren't any complaints in those other regions at all, but nonetheless, manipulation is identified on examination and manipulation is performed pretty much full spine, in 98941 or 98942 is billed. In the scenario where the complaint was restricted to the neck and the upper back, even though manipulation may have been performed to 3, 4, 5 regions, we only have justification to bill two, because payers will normally only allow manipulation in the region of significant complaint. So the takeaway from this is, one, don't develop the complaint beyond what the patient picked up the phone for. If they're coming in for head and neck pain, deal with the head and neck pain. If you want to adjust the other regions of the spine on a supportive basis, fine, document it as such, but don't include it in your claim to the insurance carrier. I mean, and it's not purposefully down coding your service; it's coding the level based upon uh, the necessity justification in your records based on the complaint. Um, Beyond that, I would say just focus when you're billing insurance on the area of complaint. All that other stuff will be there when you're done. You can pick it up on maintenance care on the back end. It's not going to significantly worsen if your care plans are normalized, 3, maybe 4 weeks tops. So the best situation is only focus, draw a box around the region of complaint, treat that, and it will build diversity in your CMT profile that makes you a less likely audit target. Um, Finally, or no, not finally, the fourth thing I've noticed is that um, the way manipulation is documented, meaning relative to regions of the spine or the specific bones, vertebral bodies that you manipulated, doesn't necessarily gel with how subluxation levels are defined and the regions are defined. So when you think about the barriers between each region, C7 T1, T12 L1, L5 S1, the SI joint, the regions of manipulation are defined by the articulations. So the cervical region is C0 through C7. Okay, the C7 T1 articulation. So if you were to manipulate C7, it it necessarily is going to influence the C6 7 articulation, the C7 T1 articulation, in which case it's a manipulation to two regions in one shot. So when you're documenting your manipulation, it's recommended that you document the articulations and therefore regions influenced by your manipulation. If you're in the middle of of a region like T5, it really doesn't matter. But when you're at the borders, okay, so when you manipulate L5, it's going to influence L4, L5, which is lumbar, and it's also going to influence the lumbosacral articulation, which that's the sacral region. The pelvic region isn't the pelvis, it's the sacral iliac articulation, right or left. So dropping on the sacrum hits two regions because you're getting the sacral region between L5 and S1, and you're getting both SI joints articulations at the same time. So when you remember that region is defined based upon the articulation, not the bone, and you document your regions appropriately, consistent with your levels of subluxation, then you should be avoid confusion by the payer that we have to sort out in post payment review. The next thing is treatment orders. Oftentimes, payers complain and want to deny care as being not sufficiently documented to establish the necessity of the services based upon the lack of detail as to how a service was performed. So, say you document eSTIM for 15 minutes. It's not a time based code. 15 minutes tells me it was performed long enough to do something, but what kind of eSTIM was it? So document the protocol, the area where it was applied so that they can validate that there's objective findings in that region and that there's a condition that you're actually treating with the electric stimulation. Ultrasound, take your pick. Pick any therapy, therapeutic exercise. You need to specifically detail what you're doing, where you're doing it, and in some cases, especially with procedures, who is doing it. That will also, touching back on the delegation discussion we had earlier, it will also help you with delegation because when you establish a precise order that, and I don't want to offend any chiropractic assistants that may be listening to this, but when I was an assistant, I used to think of it in terms of write me an order that Mike the monkey boy can follow. Turn the knob here, do this there, do this therapy here, do this many sets of this exercise, so many reps. You have to tell an assistant who's unlicensed exactly what to do so that they're not exercising decision making. Because as soon as an assistant who's unlicensed exercises that decision making, the service no longer becomes billable under your name and NPI number. Finally, the last issue is medical necessity. Um, Payers cherry pick cases if they're doing probe audits, and in the last series of cases that I've been through, they cherry picked the cases very very carefully, and they picked all the cases for patients that have been coming for years, similar problems, and they're on ad hoc schedules, meaning they present once, one and done here, two and done there, or they're presenting predictably once every 3 weeks or 4 weeks, or fill in the blank once every. And a medical necessity argument for those kind of cases is almost impossible because the patient is going to be no better at the end of care than they are at the beginning of the care. At best, we could argue that the care is palliative. And the only thing that was salvation in some of those cases is the payer didn't clearly articulate the correct basis for their medical necessity concern. So it gave us something to argue and lead towards a settlement. But You have to remember when a patient has a air quotes significant health problem causing significant impairment, these are patients that you don't have to convince to come 3 times a week. They're coming because they can't live without it. And when they don't need to come 3 times a week, it's over. So you want to develop a profile where you're doing short, deliberate courses of care with good outcomes. Don't forget to document, the actual changes to the objective problems during the course of care. And do yourself a favor when you switch them over to maintenance care at the end, which you should, or dismiss them at your call or the patient's call. um, Write a discharge summary that indicates what you accomplished with the treatment. That is your best salvation. If you're not tracking objective changes throughout the course of care, that's the way you save a case, where you specifically indicate the motion benefit, the changes in the severity of subluxation or radiculitis or whatever the problem is. Write that. Um, uh, Write that summary at the end. Indicate that you made recommendations for maintenance care. Fine. Patient agreed, didn't agree. That part I don't care about so much. I mean, you do. I mean, you want to convert these patients to maintenance for cash, so you keep them in your circle. But at the end of a course of treatment, it's got to end, and it should have a definable end, and it shouldn't be an end that is dictated by the patient. When the patient quits showing up prior to the end of your proposed care plan, it suggests to me and most auditors that the patient didn't need to be there in the first place, and that the only result obtained was palliative care, and you leave a door open for a payer uh, to beat you up on medical necessity for that reason. And for the docs, I know what you're saying. Well, so I'm going to lose a medical necessity case because the patient self terminates. Yeah, you will. So and unfortunately, the patient is often the biggest impediment um, to establishing medical necessity to care. And when they're not showing up because, oh, I have a hair appointment, I can't come today, that means they don't need covered treatment in the first place. So keep those things in mind. I hope this was helpful, and I look forward to seeing you again on a future topic. Next week, you'll have another presentation. I don't know who the presenter is, but I'm sure it's going to be awesome. So be sure to go check it out. I think it just showed up on the screen. So see you next time.